As we turn to our final speaker, we shift from the medical and research issues to the more practical issues confronted by LHON families every day. I've had the privilege of speaking with dozens, if not hundreds, of LHON families, and I've realized that while there's information I can provide that's helpful, there are also issues about which I'm not equipped to advise. I'm telling people with LHON to tell all their maternal relatives about it so they can share this information about risk factors of smoke and alcohol, and so that, if they have any visual problems, they'll know to talk to their doctors about LHON rather than going on the medical mystery tour that many of us have gone through because we didn't know we had the mutation, and that seems so practical and so wise, and yet I talked to some people who say, I tried telling my maternal relatives, and that talk didn't go so well. I learned that there are people who specialize in helping people understand this kind of information. There are genetic counselors who are trained to support people coming to terms with the issues that relate to carrying a genetic disorder, and they're trained to help people like that. And yet, since LHON is so rare, they know genetic counseling, but they don't know LHON, and you really need both to be helpful. My first thought was, I'll go out and try and educate all the genetic counselors in the U.S. so that when anyone happens to need one, those folks will know about it, but that's a little bit impractical. Fortunately, I stumbled upon the fact that there's a company that has a focus on other vision disorders, and they offer phone-based genetic counseling. And I thought, wow, so much easier to train somebody about LHON, and they can then be available for people all around the country, so that if anybody is in need of telling a family member about genetic counseling, they can tell them about this service. I contacted somebody from that company. She immediately offered to become that connection for our community, and she's here to talk to you today. Let me read you her biography. Karmen Trzupek is a genetic counselor who has specialized in the field of ophthalmic genetics since 1997, working first in a genetics lab at the KCI Institute in Portland, Oregon. She was part of the team that identified the first gene associated with susceptibility to age-related macular degeneration. After earning her genetic counseling degree from Northwestern University, Karmen returned to the KCI Institute, specializing in inherited retinal and macular diseases, retinoblastoma, and neuro-ophthalmology disorders such as Leber's. Karmen serves on the board of directors of both the Here See Hope Foundation and the Coalition for Usher Syndrome Research. Karmen works for Informed DNA, a nationwide network of specialty genetics experts available by telephone. The mission of Informed DNA is to deliver the promise of personalized health care to life through a better understanding of family health, history, and genetics. Please welcome Karmen Trzupek.
Okay, so first I feel the need to say that I am incredibly honored and also entirely out of my league to follow the last three speakers. I think it's a really good thing that I had no idea just what I was walking into today. So anyway, wow. And I guess my disclosure, there's been some other disclosures. My disclosure should be, and I think Lissa kind of hinted at this, that I am not an expert in LHON, which might give you pause. Why do they have her here whenever she's not an expert in this particular disorder? What I am an expert in is ophthalmology genetics. So I've done clinical ophthalmology genetics for the last 12 years, so I've seen a few families with this condition. It's just such a rare condition that in any particular clinical environment, you don't see very many. And this is part of what Lissa mentioned is difficult. It's difficult to find people, as many, if not all, of the patients and families in this room know. It's difficult to find people who are really expert whenever you have a really rare genetic disease. And not everyone can travel to events like this or travel to see one of the experts. And so what we're trying to do is offer those services. The good news for you, I think, is that my presentation will be much less taxing on your brain than the last three have been, and also shorter. So first I want to tell you, I'm not going to read all of this, but tell you briefly what genetic counseling is. Many people have never encountered a genetic counselor or know what a genetic counselor is. So genetic counseling is the process of helping people to understand and adapt to the medical, psychological, and familial implications of genetic disorders. So if anybody in this room has ever met with a genetic counselor before outside of their experience with LHON, it was probably on a prenatal basis, and in the general community, that's what a lot of people think, that all genetic counselors just talk to people about family decision making and when you're pregnant and what your risks are. And that, in fact, is what the field started with probably 35 years ago, but it's not what most of us do today, and it's not at all what I do, thankfully. I've had 3 children, and I'm done with that piece. So why is genetic counseling important for LHON and for this community? It's important to help individuals understand the inheritance and the risks to their family members, but if that's all it was, I wouldn't be here either, because you've heard that the genetics, while the underlying mechanisms are very, very complex, the genetics are actually pretty straightforward, right? Men don't pass it on, women do, right? Pretty simple. Most of you can go and explain that, and so I wouldn't be here if that's all there was. The second one is a really, really big one, and it's to increase the rate of diagnosis among at-risk family members. For individuals who are on that diagnostic odyssey, who have no idea what this is and are going to doctor after doctor and trying to figure it out, when someone else in their distant family is already affected, right? That's unfortunate. And also to increase the rate of diagnosis just of the condition in individuals who are at risk, who may be able to modify their risk. It's to give people an opportunity to ask questions in a medical environment that's not your standard 15-minute medical appointment. So our appointments are long. They are typically about an hour, but I block an hour and a half. So it allows people an opportunity to ask lots of questions. We are trained to give psychosocial support, not long-term therapy, so I refer out for that for sure, but some short-term psychological support. And then lastly, national guidelines do support genetic counseling for patients at risk for any genetic disorder. So really part of the genetic counseling process is about the patient, and part of it is really for your family. So in a genetic counseling appointment, we'll do a family history. So you've seen some of the pedigrees or the family histories drawn out. So we do those on all of our patients and assess risk in other individuals. We discuss the background genetics, make sure that patients understand that, talk through testing options if that person is interested in being tested. Or a lot of times I'll get patients who've already been tested and don't understand their test results. And so I'll certainly help interpret those test results for them and walk through their test results with them. Talk about any disease management considerations. And then, when appropriate and people ask, talk about family planning options. So I don't really need to go into this because that's been done in great detail, which is good. So we'll talk about the underlying genetics with patients, go through the individualized family history. So this is kind of a typical family history with mitochondrial inheritance. So you start with a woman, and this isn't necessarily, well, it's not necessarily, this is not a typical presentation you would see in a family, because as all of you know, the women are not affected nearly as frequently. But from a genetic perspective, this is what a family might look like. So this person carries the genetic mutation. She would pass it on to all of her children. Then her daughter would pass it on to all of her children. So genetically, it might look like this, though that's not, oh, that's right. I'll get to that in a second. Though that's not what it typically looks like clinically. So clinically, you might only have a couple of people in that family affected. So the question that we'll sometimes get for mitochondrial disorders or for other types of disorders that don't follow sort of that perfect inheritance model is when your family doesn't look like that, when your family doesn't look like the classic pattern, can it still be that disorder? So, you'll have a family like this, and they'll think, well, can that really be LHON? Because I don't think this is genetic. This doesn't look genetic to me. I'm the only one in my family affected. And as you've heard already, some of the LHON mutations are associated with a relatively low risk of developing clinical symptoms in women. So if you don't have a lot of men in the family, this kind of presentation might be quite likely. Also, as you just heard in the last presentation, not all genetic mutations are directly inherited, right? So this was a question that somebody asked to get a little clarification on. So all genetic mutations arise at some point. Most families with a genetic disorder have had that genetic mutation carried on throughout many generations in the family, but not all. So sometimes a person can be the very first person in their family affected with a genetic disorder because they are the first person in the entire family who carries that genetic mutation. Genetic mutations occur within our DNA all the time. We accumulate DNA mutations. It's actually what causes the effects of aging. It's what causes cancer. So DNA mutations accumulate all the time. But if you had a DNA mutation occur, say very early in fetal development at the 1 or 2 cell stage, and it happened to be in the mitochondrial genome, then as that cell divides and divides again and divides again, that would be in, if it was the single cell zygote, that would be in every single cell of your body. If it happened later, only a percentage of your cells would carry that. So it can happen in families where this might be the very first person in the family affected with the disorder because they're the first person in the family to have the genetic mutation. And we can't tell from looking at this pedigree which of those two options it is. You have to do genetic testing in family members to know for certain. In this family history, it's a little bit more perhaps common and straightforward that, yes, of course, this can also be LHON because this person in between just did not develop symptoms. And as you've heard, we just don't fully understand all of the reasons behind that. So in a genetic counseling appointment, I always think of it as, and I always try to tell patients, this is your time. So there are certain things that I try to cover with any kind of patient that I have, but a lot of the time is really about just answering patients' questions that they come in with. So if somebody comes to me and their main question is about genetic testing and whether or not they're a good candidate for genetic testing or whether or not genetic testing makes sense for someone else in their family if they already know it, because really, if all the women pass it on, does it make sense for genetic testing to be done more than once in the family, or is once enough? So some patients might have questions that are all about that. Some patients have questions more about clinical trials, and they don't understand the basis for the clinical trial, and could I be a candidate for it? In the other things that I do in ophthalmology, genetics, there's a lot of gene therapy trials going on, so a lot of patients will ask me questions about this, and they don't really understand what gene therapy is, and do I have to have a genetic mutation identified to be a candidate for gene therapy? These kinds of questions. I'm 60. Can I still develop vision loss from LHON, or am I clear? Is prenatal diagnosis possible? What is heteroplasmy? Can I be tested for heteroplasmy? What does incomplete penetrance mean, right? So these are all these kinds of questions that you might have that we would try to answer in that kind of appointment. So I touched on this a little bit before, but family outreach is important for several reasons. One is because of this concept of incomplete penetrance. So there are kind of a couple terms being thrown around about variable expression, incomplete penetrance. In the genetics world, when you say incomplete penetrance, if it's penetrant, that means everyone gets clinical symptoms of the disease. If it's incomplete penetrance, that means some people inherit that mutation, but they don't get any signs of it. So generations can be skipped, which can lead some family members to assume that they're not at risk. If it's this distant part of their family, then they assume, nope, nobody in our family has inherited it. We don't have to worry about it. You can do counseling about some of the environmental factors in at-risk family members. that may in some cases even prevent someone from losing their vision. And I think that's so important for this condition, that if we can reach out to at-risk family members and help them understand those risks and help them understand what they can do to potentially modify their own background genetic risk and susceptibility, that's really important. And then, as I mentioned before, just to decrease really the time, cost, and emotional burden associated with these long paths to a difficult and rare diagnosis. LHON is particularly difficult to diagnose. This was mentioned earlier. There's several reasons behind it. 20% of affected individuals have no changes on a dilated eye exam. Now, some people probably argue with that a little bit because that entirely depends, I think, on the level of expertise of the clinician that you're seeing. So it's probably not as high as that if you were to see certain people. But this is the published rate, 20%. The tests to evaluate for other causes of acute vision loss are often only available in large medical centers and may have a long wait time. So sometimes if a patient doesn't live in a big city or near a large medical center, it can be difficult and take a while to get all of this testing done. There are very few physicians really knowledgeable about this condition, and a lack of family history can discourage a clinician from really considering a genetic disease, and they think that it's probably non-genetic. And then lastly, of course, many physicians equate LHON only with a young male patient. So if they see a woman in her 50s going through menopause who's developing optic neuropathy, they're not going to think LHON, but that's what it could be. So in the field of genetics, there's long been this frustration that a lot of doctors will say, well, you have a genetic disease. We can't do anything about a genetic disease. There's nothing you can do. I'm sorry, you're going to go blind. So is there really nothing you can do? Well, no. Even if there weren't any proven treatments, there's still something you can do. But now, of course, there are some potential new treatment options that many of you knew about before, but if you didn't, you've heard about by now today. Also, the avoidance of things like smoking and excessive alcohol. But also, there's education and engagement with research and clinical trials, some of the psychological and social support, and then, as we've been talking about, this family outreach. I already said that. So what I really hope after a session is that patients will really understand their own disease more fully and be prepared to go back and really have more active and productive discussions with their own physicians. So, to be able to come away from those appointments you've had with your physicians with these list of questions and then feel like you're better able to understand your disease and go back with better questions. And, of course, to be empowered to reach out to your family members, to know what to say, to feel like you have the answers to some of those questions. And this is also something that we recognize is hard. I certainly, as a genetic counselor, talk to people a lot about family dynamics and recognize it's really hard in some cases to talk to family members. This is an abbreviated version of a family letter that I send out. So I send out family letters to a lot of patients where there's benefit to reaching out to their family members, but they maybe would like a little help in doing so. And it'll have a bunch of information about the condition, and it'll start out by saying, your family member has been diagnosed with this condition. This is a genetic condition. This is how it's inherited. It'll give them a bunch of information about it. This is why it's important for you to know about it, and this is why it might be good for you to be evaluated for it, and this is who you can call if you want more information. And then that's something that you can send to family members by email or by regular mail. But that's something that we provide to all of our patients. Liz already mentioned there's a reason that she reached out to me. So I'm a big proponent of good genetics information no matter where you can get it. But in particular, the reason she reached out to me at Informed DNA is because we have a telephone-based model. So There are only 2 of us who do ophthalmology genetics, so everybody who comes would get one of the 2 of us. And she, of course, is going to get a big lowdown after today. The other one. So, nationwide, there's really insufficient access to genetics experts for most people. There are fewer than 2,300 board-certified genetic counselors in the United States. Fewer than 25 specialize in ophthalmology genetics. So if you wanted to see somebody who really specializes in this tiny little field, you'd really have to go to one of the major clinics. And the wait times at the general genetics clinics are frequently long, and at the specialty genetics clinics. So this is where we try to come in. So because it's all by phone and by web, it doesn't really matter where you are. So there's no travel. We actually offer patient appointments day, evening, and weekend. We do offer interpreter services. We offer family appointments, and those family appointments, of course, you don't all have to be in the same place because we can do it over telephone conference. So if your sister is in Chicago and you live in Texas, that's fine. It doesn't matter. So we can offer those family appointments together or with you all in a room. And as I've already mentioned, we subspecialize. So our tiny little company specializes in these subspecialty genetic conditions. So we have cancer genetic counselors and neurogenetics counselors. I do ophthalmology genetics. And there's our website, so you have it in your handout. And I think that's it. So I'll take any questions that you have.